Good morning, good afternoon, good evening, wherever you are. Welcome to Virtual Grand Rounds, Premier Education brought to you at no cost, thanks to our sponsors, AstraZeneca, Medtronic, and Medela, the Science of Care. Following on from Dr. Punit Iyengar's talk last week about the radical management of oligometastatic lung cancer, it's a great delight for me to present this week Professor Elena Klenova to give a patient's perspective. Elena is also a professor of molecular oncology at the University of Essex and very active in the ALK space, for which she has been drafting some guidelines and working with patients to discuss their perspective of radical management for oligometastatic cancer. Elena, over to you.
Greetings and hello, everyone. And I also would like to thank Professor Lim for this kind introduction and for giving me this opportunity to present this topic to the thoracic community. Okay, so I'm not a clinician and I'm not an expert. So I'm a patient, and together with my fellow travelers, I'm very keen to find out more about how we can extend our treatment options. In this context, local consolidation therapy and surgery in particular is of great interest to us patients. In this presentation, I would like to give you patients' perspective of radical management of oligometastatic lung cancer, and with particular interest in the oncogene subtypes. A few words about myself. So my name is Elena Klenova. My background is in science. I graduated from Moscow State University and worked in research in Russia at the Institute of General Genetics and the National Medical Research Center of Oncology. Between 1990 and 2020, I worked in the UK in research and education at the Institute of Cancer Research in London, the University of Oxford and University of Essex. I was diagnosed with stage 4 ALK-positive non-small cell lung cancer in December 2017, and I underwent various lines of treatment, including chemotherapy first line, then 2 sequential TKIs and radiotherapy for brain lesions. I'm currently stable on brigatinib. I would like to say a few key facts about non-small cell lung cancer. So this type of cancer contributes to approximately 88% of all lung cancer cases. And of this category, more than 60% of non-small cell lung cancer patients from Western population have oncogenic drivers. This number is higher for Asian populations, it's about 80%. Of these patients, about 2 in 3 would have an actionable target, meaning that there would be drugs which could target particular oncogenic drivers and control cancer. This diagram gives a breakdown of these different oncogenic drivers. And at the moment, I think there are about 30 of them which are known. The great proportion of this pie chart belongs to KRAS and EGFR, and ALK fusion is about 4%. And this is a category which is quite close to my heart because I am an ALK patient. From the epidemiological perspective, oncogenic drivers are largely enriched among non-smokers, East Asians, and younger patients. And with regard to the ALK cohort, it's enriched in women. The treatment options for stage 4 non-small cell lung cancer patients are limited, and standard treatment practices include chemotherapy, sometimes in combination with radiotherapy as first line if there are no treatable, targetable biomarkers. Targeted therapy as first and often subsequent lines is used when there are targetable biomarkers. When they are exhausted, chemotherapy will be used. for the patients in this category. With regard to local consolidation therapy, such as surgery or radiation, usually it's used in this setting to treat sites of progression. There are, however, emerging treatment practices, for example, radical management of oligometastatic lung cancer, which is more or less a subject of this presentation. Surgery of the primary site in particular in this category. So when we say oligometastatic lung cancer, we mean 3 secondary sites or fewer, but nowadays I think this is expanded to more sites or even polymetastatic patients. So usually this is applied after systemic treatment first line when it's successful. Radical management can be particularly effective in combination with targeted therapy, where this is applicable, where there is a targetable marker. I have to say that the views about the LCT for patients with stage 4 non-small cell lung cancer within the therapeutic communities are polarized. And this is particularly notable in the UK. The main arguments against the LCT are as follows. So results from clinical trials are not conclusive or sometimes even inconsistent. It may not be obvious for the surgeon what area or areas exactly they need to resect, or if it's radiotherapy, they radiate. LCT, in particularly surgery, may impact on cancer biology because of formation of active components around the treatment area, and this may result in reactivation of dormant cancer cells. Metastasis to metastasis spread is still of concern, even if the primary site is removed. There are also arguments in favor, of course, and which is good news. And the main are as follows, that targeted residual lesions prior to disease progression using preemptive LCT could prevent or slow down the spread, local symptoms, and also complications which are associated with tumor growth. This is particularly relevant to oncogen-driven non-small cell lung cancers. And this is because despite the efficacy of tyrosine kinase inhibitors, TKIs, which these are the drugs which are used to treat oncogen-driven non-small cell lung cancer, most of them, the minimal residual disease remains usually, and the acquired drug resistance occurs inevitably. Nowadays, the LCT techniques are quite advanced, and for example, video-assisted thoracic surgery, VATS, is applied in many situations, and this can reduce side effects. And this is another point of criticism from people who argue against the LCT. So we can answer that here. A continuation of systemic treatment, such as targeted therapy after surgery, can reduce the risk of cancer reactivation. In support to us who are advocating for LCT, there are now 3 reports from different medical organizations, very serious medical organizations, which provide practical guidance as to how to conduct the treatment in such settings, in particular for oligometastatic non-small cell cancer patients. So 2 of them were published in 2023, and this is a report from AstraZeneca organizations. And the second one is a report from ESMA and CBS. So they both strongly support the use of LCT for metastatic patients. So I will not go into detail, but these are just highlights from and extracts from these reports which illustrate the point. I would like to talk more about the most recent report, which came out from the Society of Thoracic Surgeons in January 2025. And they also practiced an updated clinical practice guidance on the management of oligometastatic non-small cell lung cancer. This was conducted by a panel of thoracic surgical oncologists, and they included Mara Antonov, who is a lead in this area in the US. So the recommendations which this panel produced, and they are in line with the recommendations produced with two other panels, are as follows. So all patients with oligometastatic non-small cell lung cancer should undergo a multidisciplinary evaluation, including consultation with an experienced thoracic surgeon. Moreover, lung resection should be offered to appropriately selected patients, regardless of the number of sites of disease. More data are needed to determine the potential impact of lymphadenectomy surgical approach and extent of resection. So, of course, these reports totally agree with the fact that more data need to be accumulated from clinical trials which are ongoing and are maturing as we speak. I have to say that these recommendations they haven't been reflected in the current NICE management guidelines, and NICE is a UK health governing body. So we are very keen to find out what the NICE and also the BTOG, and this is British Thoracic Organization of Surgeons, what their comments would be about this and how this would be implemented in the practice. I would like to present you some very recent data from a publication. This is from Mara Antonov's group. It's not a full paper, but it is a snapshot of the results which they have got up to date with regard to the trial, showing that surgical resection for stage 4 non-small cell lung cancer results in greater overall survival of patients. So this is a diagram with a blue line showing the overall survival of patients, and median survival is 80 months, 80. So this is remarkable, and this is in comparison to data which shows that if the chemotherapy is used as a first line, the median of survival, overall survival, is less than 16 months. So this graph at the bottom is from a different study, but it's typical. Actually, it's showing an optimistic outcome for patients. Usually, other data would show that the overall survival is less, median of overall survival could be less than 16 months, between 9 and 12. So it's a remarkable difference between these two situations. So we are very keen to see how this number, and which covers the total cohort of patients who underwent the LCT, how it could be stratified further into specific patient categories, including categories of oncogen-driven lung cancers. As NALK positive patient myself, I'm obviously keen to see how different cohorts of these clinical trials are doing. And this particular clinical trial, which is called Bright Star, is focused on the ALK positive cohort. So they are comparing the effects of brigatinib combined with the LCT with brigatinib alone. And as you can see from this presentation, or from Dr. Elamin, this is a snapshot of his 2 slides, screenshot, sorry. There is very promising tendency, trend to see a difference between these 2 cohorts. So the progression-free survival is much higher in the category, in the bright star category, where brigatinib is combined with LCT. So I understand that this data will need to mature, and they are being collected through several years, but we are very encouraged by these results. As patients, and I am a part of NALK positive community, we are very keen to find out what's going on in the UK, how these practices are used. And I have to admit that LCT for metastatic patients is a very rare event. So it's very difficult to find any cases really to present. But there was a patient in our community who was happy to share his experience, his journey with us. So this is his case. This patient was diagnosed with stage 4 positive non-small cell lung cancer in 2020, and he started on TKI, alectinib. He was very keen to have surgery, and he started discussion with his oncologist and the surgeon. In 2022, the process of evaluation of his situation started. And in 2024, the surgery was performed. Since 2024, he had stable results from CT scans. The MRI scan showed the increase in brain lesions, but they were initially discovered well before the surgery, so they are not new, they are not linked to surgical procedure. So these lesions were treated with SRS, and this patient is currently monitored for these lesions. The patient stated that he firmly believed that the surgery was the correct decision for him. It had not only physical but also psychological benefits, and he has to admit that it was not an easy journey, so he had to work very hard to have the surgery. But he's doing well, and he also wants to make a point that the surgery may not be for everybody. So each case is specific, so surgery may not be appropriate for everyone. We took this with my colleagues, we took this case a little bit further, and we presented a poster for the 23rd annual British Thoracic Oncology Group Conference in 2025. So this is this poster. I wouldn't go into detail, but it describes step to step, very detailed journey of this patient, and it can be also found on the website. Together with my colleagues from the ALK positive community, we also prepared a paper, a document for the thoracic community to discuss the possibility of LCT for our cohort of patients. And with the ALK cohort, it's a known fact that almost 85% are diagnosed with stage 4 lung cancer at the moment of their diagnosis. So we prepared a document, and these are 2 pages, the screenshot of the first 2 pages. It's quite extensive, and it describes in detail the current situation as we understand, we patients understand it, and it explains to the thoracic community what patients would like to do. There is a full copy, obviously, and I'm happy to share it with anybody who would like to have it and give us any feedback. So you can email me, and I'm happy to send you the copy. We would like to hear any feedback from the thoracic community. We would like to hear our case answered. So to conclude, I would like to summarize various points which I raised today and more in this summary of patients' perspective of radical management of oligometastatic lung cancer. A growing body of evidence supports the use of surgical resection of the primary lung tumors as LCT for stage 4 lung cancer patients. And as an example, I would like to mention ongoing clinical trials such as Lone Star, North Star, Bright Star, and others. Medicine development and implementation processes might take years, whereas there is expertise, there are skills and capacities to carry out the LCT procedures, and they are currently available. We acknowledge that not all patients may be eligible for LCT, but believe that a substantial group of patients can benefit from this procedure. The routes and pathways to be referred for surgery will need to be clarified to allow fair access to treatment. We also suggest to broaden the criteria for clinical trials and referrals to include wider cohorts of patients. For example, patients with a disease history. I would like to mention here that this is quite hidden in the community, that most of these clinical trials enroll newly diagnosed patients who had successful systemic treatment. So patients with disease history normally are not included. And in fact, patients with disease history may be downgraded in their assessment to stage 3 or even to stage 2 because they may not have distant metastasis anymore. So this inclusion of this patient cohort would be beneficial for the future clinical trials. The Society of Thoracic Surgeons and other medical organizations in their guidelines are sending a positive message to patients about the role of local therapies, including surgery. As patients, we want to be perceived as active and collaborative part of our treatment journey. We are very keen to learn about our conditions and anticipate that we would have access to the information we can trust. Expanding treatment options is important for us, and the time is of the essence for us patients. Surgery as part of the LCT for lung cancer patients with advanced cancer will bring hope for a better future for us patients. I would like to acknowledge the contributions of my fellow patients, Stephen, Gilly, Neil, and Sean, Duncan, Deborah, and Graham. I would like to say a big thank you to Professor Eric Lim and Fiona Blackwell for their help, and Yvonne Diaz and John Clark from Oncogene Cancer Research UK charity, and who are also helping us a lot to take our case forward. And I would like to thank you for listening and welcome any questions. Thank you.
Thank you, Elena. That's an amazing presentation, and thank you for all the work that you've done with regards to patient information and advocacy. And it's really good to see that patients are also reading the international guidelines. And I think what we are looking at and summarizing in this session this week is that the interesting opinion that all professional societies, and we're talking about ESTRO, ASTRO, ASCO, STS, agree surgery as part of local consolidation treatment and recommend it for patients with oligometastatic lung cancer, but yet it does not penetrate down to the individual doctor's level who are not offering it routinely. I think many doctors are so cautious or perhaps overcautious on concern that they are not uh, providing treatment in the best, in the best manner, and hence retract from it rather than actually embrace it. Can I ask what has ALK positive, future steps or publicity, what's planned to help educate your opinions to the local doctors here in the UK?
Thank you for this question. I would like to say that in addition to this document, which we prepared with my colleagues for the thoracic community, we are trying to raise awareness not only from patients, but from the whole society about the expanding this treatment option to include surgery or LCT. So Yvonne Diaz and John Clark, who are from the Oncogen Research Cancer charity, are starting the social awareness campaign to promote this situation further. So Yvonne Diaz is preparing a surgery series, and they will include a page for the website. So it would include case studies, and I know that I presented the case for the outpatient, but there is another patient who has different oncogene driver, EGFR, and this patient had a surgery. She's also a patient with stage 4 lung cancer. So she also is willing to share her story with the lung cancer community and also with the thoracic community. So this patient stories will feature in this campaign. So I know that Yvonne is also organizing a podcast with you, Professor Lim. So I know that you were very willing to be involved in this campaign, and we are very thankful for you to support us. So there will be a lot of questions to you. We already think gathered about 45, but we promise that we will try to compress them, and there will be less. But so you can see from these examples that we are very keen to promote this case and raise awareness among patients and among thoracic communities that this is a feasible option for us, and it can bring better future.
Thank you very much. So one of your questions you mentioned, why hasn't the NICE guidelines addressed this issue? And I think that the principal reason is that the NICE guidelines are estimate of cost effectiveness of treatments in the United Kingdom. And you may know that I led the Ramon study. And in the Ramon study, I think it would be fair to say that we didn't receive widespread support from all centers across the UK, and therefore we were not able to recruit into this important study. Now, in the Ramon study design, we actually had very detailed health economic analysis with help and assistance from the University of Oxford. But obviously, we never got to that stage for health economic evaluation because we were not able to recruit. So that's a real pity. In the absence of UK generated health economic data, I think it's very unlikely that NICE would be able to be in a position to issue any statement going forwards with regards to cost effectiveness for local consolidation treatment in oligometastatic lung cancer in the United Kingdom. And also coming back to some questions in your talk about early versus late, where should LCT be given at the point or or continuously? And actually, we don't have any answers to that. And even for the Ramon design, we had 2 points of entry for LCT. You could enter at the point of diagnosis or you could enter at the point of disease stability. And despite widening our entry criteria, again, we were not able to recruit. Um, so some questions from the audience. There's one from Dr. Jafani who's asking if the NGS panel was negative for ALK but positive for immunohistochemistry, what to do with that. And certainly, of course, there's no rigid recommendations in the LCT setting, but for the Ramon study design, we accepted immunohistochemistry positive ALK as a point for entry, and I think it's also widely accepted in the UK as a point for treatment as well. Um, a question from Dr. Al Bulushi, who's asking, in our experience, how can we convince surgeons and patients with this approach? And that's a great question. I think there are two parts to the questions. Uh, I don't think patients need to be convinced. They just need to be presented with the evidence. And I think the evidence needs to be presented in a fair manner. I think it is true to say, before last week's presentation for the NRG LU002, LCT was recommended throughout. Now, with the presentation of and publication of NRG LU002, I think the global community is going to take a pause on this. What I do understand from Dr. Iyengar's presentation last week is that for the general non-oncogene driven cohorts, this may not be improved overall survival. But we still don't know very much about the EGFR and the ALK positive, and we're waiting for MD Anderson and the Memorial Sloan Kettering collaboratives with the Lone Star and Bright Star for their data on specific oncogene driven cohorts, whether or not that would generate patient benefit. So there's lots more to come. And this is a very fast moving space. And so there are always so many more questions than we have time for answers. So unfortunately, it leaves me to thank our sponsors, AstraZeneca and Medtronic, and Medela, the Science of Care. Next week, we have Professor Paul Van Schil, who'll be talking to us a little bit about salvage surgery, initially after chemoradiotherapy and now after immunotherapy as well. And finally, last but not least, Elena, thank you so much for giving such a detailed presentation, conferring your views and that for the ALK Positive UK as well. It's certainly contributed to our understanding as surgeons, and we hope to be able to support more of these activities going future with you. Thank you so much.
Thank you.
Have a good day.
Thank you.
Bye bye.
Bye bye.